guys, welcome back to Medical Coding with Blue. Today's episode is all about what is medical coding. If you are brand new to my channel, welcome. I am Blue, I'm a medical coder. Okay guys, this episode was inspired by a viewer comment, so I'm going to read the comment and then we're going to get into the answer. But first, a little housekeeping note first. If you guys are going to ask a question, please try to refrain from prefacing it with, this may be a stupid question, or maybe you've heard this question before, or something of the sort, something similar. Guys, just ask the question, okay? And please be very specific in your question. I like direct questions. I like questions that have a beginning, a middle, and an end. Meaning that it lets me know, what are you looking for? I have been getting incomplete questions where I have to ask a follow-up question to even know what the person is trying to ask me. So please make sure that when you're sending in questions, I don't mind answering questions, but I do encourage you guys to make sure that you're doing your research first. If you're asking me about like AHIMA or AAPC, go to the website first. That would be the best place for you to get those answers and get them faster than I can respond. So that is my first bit of advice. And the other thing is, guys, again, I don't mind answering questions, but it really does help when I know exactly what you're looking for. So that aside, thank you so much to the viewer who sent this in, and let's go. All right, so they said, this may be a stupid question, but wouldn't it be easier and more efficient to use a highly sophisticated AI robot medical coder / biller? Is this career dying off and becoming obsolete like transcription? Okay, so let's get rid of a misconception here. Transcription is nothing like medical coding. Transcription involves where you're listening to the doctor and you're transcribing the op note, or the op report, the operative report, or their notes. So you're transcribing them, so you're typing them out. There is a bit of technical skill that goes involved with it, but it's more of, okay, well, we need to format it this way, and the spelling needs to be correct, and the brand names need to be correctly spelled, and the letters and everything needs to be correct on those things. So there is that with transcription. It does not involve comprehension like medical coding does. Medical coding involves comprehending the documentation into codes for insurance or statistical purposes. So there's a huge difference between the two. Now, yes, there have been things like an encoder that was developed, which is an encoder, if you don't know, it's like an electronic code book. So basically you type in a couple of words and it will take you through a decision tree, which it will give you the code at the end where you can enter that code into the system, whatever electronic medical record you're working with. So there is that. You can use that for that. But sometimes with the encoder can actually take you to the incorrect code. It'll give you a code, but it can actually be incorrect if you've selected the wrong decision in the decision tree. So there's a difference there. I've seen it so many times where coders come up with something like it's an organic diagnosis when it actually should have been an injury code. And so there's two different things that happen there. And if you're not familiar with the coding itself, you can put the incorrect code in there, and then there's a whole bunch of other issues that go along with that. So there's that. And yes, while that helps to speed up the process of the coding is still based on comprehending, again, what you're reading and reasoning out what is being documented. Because there are AI, the artificial intelligence, of course, in the electronic medical record, and some of them, that's real sophisticated, where it will pull out the diagnoses and it'll try to get a level for E&M, it'll try to get the procedure code. Oftentimes, these codes that are being selected by this system is incorrect because it's actually looking at words. It's not looking at, okay, the sum of all these parts, which is what the human element is for us medical coders, where we can look at it, reason it out, and say, okay, no, it's actually going to be this code, or it's actually going to be this level. So yes, there are electronic medical records that do have this capability, but it does not guarantee the accuracy. And again, a good medical coder will be able to make that distinction and make those corrections. So let's just get that out of our thought process. because a lot of people say this. They've been saying this since before I started, and I became a medical coding student in 2007. I got my certification in 2008, and I have not been working, meaning that I really love what I do, since 2014. So ever since then, I've said that I love it so much, it's not work to me anymore. But yeah, so that is that whole part, okay? So there's a lot of things about medical coding, but the gist of medical coding is when you go to your doctor and you have your doctor visit, and the doctor has to decide, you know, or has to diagnose you with your issue, or maybe you're already coming in as an established diagnosis, like you have a certain condition that you've been carrying with you. And so the doctor says, okay, we're going to check you out for this, and then we're going to see if you have a new problem or whatever, because maybe you're complaining about something. So the doctor does their workup. They document in an electronic medical record, because majority of places are electronic now. And so they go through and they document all of these things, and you get a diagnosis, obviously. If they do any procedures, they document how the procedure went and what did they do, and they give all the particulars of this procedure. And then sometimes the doctor is eligible, or not just a doctor, but a PA or an NP, eligible for an E&M level or evaluation and management level, and that is basically the cognitive work of the provider. So there's levels, and these levels, the higher they go, the more complex this doctor had to use their brain. So that is what E&M levels are. There's a lot of different things when it comes to medical coding, but that's just kind of like the broad strokes of it all. The diagnoses are technically called ICD-10-CM, right? This just means that we are in the 10th, the 10th classification of this, of our diagnoses set. So that is ICD-10-CM. There's CPT, or current procedural terminology, and that has to do with all your procedure codes. It also houses your evaluation and management. That's that cognitive work levels that I talk about. They're housed in that book. And there's modifiers that are in that book as well. And modifiers can be added to evaluation and management codes. They can also be added to procedure codes to tell more of the story. So for instance, if you go into your doctor and you have a injection for pain relief on your knee, you might get assigned a code, the procedure code 20610, which is arthrocentesis of a major joint. The knee is considered a major joint. Now, if you only had this done on one side, there's the modifier RT. Like if you had it done on the right side, we would add that RT to that 20610, because that would tell the insurance company, hey, they had this major joint injection for pain relief or whatever else, drawing off the fluid or anything else that's involved in that code. Based on their documentation, it's translated to that, and it was only done on the right side. Okay, great. So that's how you would come up with something like that. And then of course it would be whatever the diagnosis is. Let's just say it was for osteoarthritis of the knees, right? Say you have osteoarthritis of the knees in both knees. That's code M17.0, bilateral primary osteoarthritis of the knees. Okay, this says that you have osteoarthritis in both knees, but this procedure that you just had was only done on the right side. So that tells, again, more of the story. So that's how those types of things start, and that's how it gets documented. Then it goes to the coder, and the coder is the one who looks at it and says, okay, maybe the doctor didn't pick up the injection, maybe they didn't know the code for that, or maybe the system didn't pull that code for it, and they just selected an evaluation and management code. Well, part of that that injection code, there's an element of evaluation and management in it, and there are some procedures that are that way. That's obviously a more advanced conversation than what I have time for here. But in this case, if that was all they did, they would only get the injection code. So me as the coder, if I was to see this and there was an E&M there, I would remove the E&M level because it doesn't apply. because if all they did was the injection in our fiction patient here, then I would just code for the osteoarthritis of the knees, and I would code for the injection, and I would code with that RT modifier to say that this was only on the right side. Now, yes, there's other codes that you could pick up as well. The medicine that was injected, for some places they do pick up that code as well. That's a HCPCS code. So there's also another code set called HCPCS Level 2. And that covers all of your durable medical equipment, your bandages, medications. It covers all of those things. And it's something that you'll learn in your program. And I could potentially pick up that medication with that as well to let the insurance company know this was what was injected into this patient. Okay, so after I do all my magic and I send it on, right? I enter it, I complete it. I've done my review, I've updated the codes, or I've added the codes as applicable. Whatever is there that didn't get picked up by the system, that didn't get picked up by the doctor, I will pick it up, and I will make sure that it's very specific to that patient and that encounter, whatever's documented, and then I will complete it. And then it goes off to the billers. So then the billers get it, and then they send it on to, they do their magic as far as like preparing it for submission to the insurance company. Now, I have never been a medical biller. I've only been a medical coder. Yes, there are some medical coders who also do the billing. There are some medical billers who also do the coding. But that is, it's generally two different functions, and most times it's done by two different people. Sometimes it's done by the same person. It really depends on the size of the facility or the doctor that they are working for. So that's how that comes into play. So that's something that it really depends on where you are. If you don't want to be a biller, that is okay. I have never been a biller. I started my career as a medical coder, and that is what I've stayed at. I do know some things about billing because I do my own research, and I've been in the field long enough to know a thing or two. So that's what happens there. So the billers get it. They send it on to the insurance company. They collect the money from the patient, like the co-pays and anything like that they need to collect from them, and then they do their thing that way and get the provider paid. And that is how the cycle goes in a very short version. So hopefully that answers that question on that. But the second part of the question was, but where do you enter the codes? Do you just submit a bunch of codes to the billers or the insurance company? Is there a coding form you fill out? I'm confused. So a lot of this will be clarified once you get into a program and once you start to kind of understand the whole process of using the electronic medical record. Because we do use the electronic medical record, and we enter it into the system there based on what we have for documentation, what we see, and then it goes on to, it gets put like into a queue. Let's just say for simplicity's sake, that it gets put into a queue, which is like a list of all of the encounters that I complete. It goes to a queue list for the billers to start processing. Okay, this patient has this insurance, that insurance, and we're going to send these bills out. So that's what they do on their end, so that I don't have to do it. It's just, I'm just reviewing the documentation because it's so complex what we have to do as coders, and then what the billers have to do. They have their own equal tasks, but they have something that's more routine. Whereas with coders, we see a lot of different things. Now, billers have their share, especially with these insurance companies, because each insurance company is different. And then it's based on just different factors, you know, the age of the patient and everything else. You know, some are Medicare patients, some are Medicaid patients, some are commercial insurance patients, and some are self-pay. So it really all depends on what insurance that provider or that group or that facility accepts. So again, that responsibility falls onto the biller. So try not to think too far ahead about like the ins and outs of like how all of this stuff works. If you are in school and this is your first time learning about medical coding, this is just just a general introduction to what it is. All the intricacies will be figured out once you get to your facility, because there is a difference in how some facilities will handle these things. So some facilities will have the coders work very closely with the providers. If there's a problem with the documentation, maybe there's something that is missing, the coder is responsible to query or ask. You're sending a question to the provider to clarify without leading, okay? Because we can't lead. We can't tell them, hey, you did this, but did you really do this? We can't say that. We have to give them options. And there is a template on the AHIMA website that I believe everybody can look at. But there are tons of query templates out there to kind of get you familiar if you are curious about that. But with those queries, it does require you to talk to the provider. Some places will have one person who does that, who does all of the communication with the providers, and the coders just code. So if there's a query to be sent, the coder will send it to the educator, and the educator will look over it and say yes or no, and then talk to the coder or go and talk to the provider. Me personally, I like a hands-on approach. I do not like anybody talking to my providers, because if somebody has a differing opinion of how things go, and if they're not following the coding guidelines, which sometimes that can happen if you get into like a rut where you're not looking at the coding guidelines every year, and you kind of stay doing the same thing, and maybe those guidelines have updated and you didn't check it out beforehand, and you kind of keep doing the same thing, and oh well, the insurance always pays it. The insurance is not responsible to say like, okay, well, we're not going to pay. They can deny. Okay, yes, they can. But even though they pay it, it doesn't mean that that's actually accurate. They can actually go back and audit and make sure that that's actually correct. And if it's not, the insurance company can say, oh, you know what, we paid you all this money, and this is actually incorrect, so we want our money back, and we want interest. So they're able to do that. And so that's why it's very important to constantly stay up on your coding guidelines. For me, I know that if I'm the sole communicator with my providers, which again, that's my own personal opinion, that's the way that I prefer it to be, because again, if they're going to take any direction from somebody, it needs to be one person. It doesn't need to be a bunch of people telling them what to do. This is what frustrates providers and makes them mad, where they don't want to listen to anybody, because so-and-so said this, and then somebody else said this, and somebody else said this, and now they got 100 emails that say different things. You have to be consistent with these providers. They do not have time for foolishness or tomfoolery, where there's just a bunch of different egos running around. You can't have that. So this is why I always say, no, my providers are mine, and their coding education is my responsibility, because that's the way that I've always been. So it's worked out. They do very well, and I'm very proud of them for that. But it is a constant thing that I have to go through with them to keep them all straight. Because sometimes your providers will be doing great and everything will be good, and then they'll go to a conference, or they'll talk to a friend who went to a conference, and all of a sudden they have these different ideas now, and they think, oh well, my coder didn't say this, so I'm going to start doing this. Oh no, that's not how that goes. Because for some places, different parts of the US, insurances are different. So there's different rules, right? And because of this, and you can see that by going to the Navitas website, it'll ask, what state are you in? Because there's different rules. And so that's something that you got to watch for. And so that's why I have to tell my providers too, is that it doesn't always mean that that's actually correct. And again, if the person that's educating that provider is not up on their P's and Q's, they can actually share information that's just like, okay, what are you doing, right? And so again, I say that all of their education is bestowed to me as their coder. And so I have to make sure that I stay on top of those guidelines, as you should, being a medical coder. This is why I always strongly recommend that you all read the coding guidelines. If you are in your program, you can actually download for free off the CMS website, cms.gov, the Centers for Medicare and Medicaid Services. They do have a free copy of the ICD-10-CM diagnosis official coding guidelines for ICD-10-CM. So download them. They have the current ones, so that way you can start reading them once per week. And the reason that I recommend reading them once per week is because it'll make you a faster reader. In medical coding, we have to learn to read fast because we are put on productivity standards and accuracy standards. So even though you might read slow at the beginning, we all read slow at the beginning. Trust me, I read slow at the beginning. I'm still a slow reader sometimes. I have to slow down and really kind of look at what I'm reading. But for the most part, I can take in a lot of information now very quickly. And I do this because I read quite often. I love books, as you can see. But I do read quite often, and I do recommend that for any new medical coder. It's about getting yourself conditioned to start learning to read a lot. And the guidelines that are on the CMS website is like 115 pages, but don't panic. It is just the font size. That's all it is. When you get your coding books, if you get the Optum 360 coding books, this is not an ad for Optum 360, but I love Optum 360 because I think that they are the best books for any medical coder because of the information that they have in them, and I highly recommend them. Okay, and they are eligible to be taken the tests with. Whether you're sitting for an AHIMA credential or an AAPC credential, you can use the Optum 360 coding books for your diagnoses book, your ICD-10 PCS, that's the inpatient procedures, and the HCPCS book. You can use those. The one that we all have to use that is the same is the CPT manual, the professional edition by the American Medical Association, by the AMA. So that is that there. But once you start reading and getting into that reading, you will become faster over time. Even if it takes you a few days to read the coding guidelines thoroughly, it's okay. The more you practice with it, the faster you'll get, and the more it will commit to memory. You don't have to memorize, but you do have to be able to recall these things quickly. And again, if you are doing this practice, it is going to help you tenfold. And I tell this to new medical coders all the time. So if you want to get in it and you want to start looking at it, and maybe your program's starting off a little slow and you kind of want to move things along, start reading those coding guidelines, because again, it will help you. So that's just my advice anyway. But I hope this has clarified what medical coding actually is, and the importance and the uses of this information. We can get so much good data from these codes, right? Because you could tell a lot about a population based on like what diagnoses or what procedures a population has. You know, a few years ago there was, I'm going to say this really quick because it might cut me off. In Colorado, there was a lot of skiing accidents, right? There was a lot of spiral fractures. Well, why were they having these spiral fractures? Because when you go down the slopes on the skis, right, these are very high velocity accidents. And so because of this, there was a public awareness campaign that was put out because they saw a lot of the same diagnoses, these spiral fractures. And so to prevent them, they did a lot of safety, infomercials, and so that did help a lot. So there's a lot of good things that can come from this information that we collect as medical coders. So I hope that you will like and subscribe, and I will see you guys next time. Bye.